Welcome to HiNZ 2018, and today I'm talking to Lesley Holdsworth. And Lesley is the clinical lead for digital health and care for the Scottish Government. And Lesley, I sat in on your plenary session yesterday where you spoke about the Scottish approach to digital healthcare and the strategy, very wide sweeping and interesting strategy. And you talked about patient self-referral systems as was an influence, perhaps, in some of your research in the strategy, and how Scotland was similar to New Zealand as well in many respects. Another key thing that you mentioned in the strategy was self-management, self-support, and anticipating self-support. So can you just elaborate on some of the highlights that you spoke about?
I talked about yesterday, I mean, we've got a problem in Scotland that everybody has in the world in terms of management of long-term conditions. A terrible burden on individuals, on families, and health and social care providers. And we've really got to do something quite dramatic about that. We just don't have the capacity, the resources for the predicted numbers of how much this is going to increase. There's something like it's due to double in terms of, but in the next 7 years, I think the predictions are we already have 46% of adults with at least one term condition, and comorbidities after the age of 60 sort of really start racking up. So I think as a nation we've recognised this, as many others have done, and are trying to put in strategies to help us manage and make lives for our citizens as comfortable as possible and as independent as possible. So a major emphasis within the strategy is on, if you like, I like to say, at the real back door. So it's not at the front end when we get into crises, when we're having to manage a lot of things. So in terms of prevention, in terms of empowering people to really take the right steps in within their own lives, and also for their families. So we do have, so part of our digital strategy is to look at developing more solutions at that end. So, for example, we have a national information provider. So we're really beefing up the resources and the types of resources, media. So yes, you've got online, but you've also got opportunities for people to, for example, access TV channels to get this information. The information can be in various digitized formats, but it's primarily aimed at promoting self-management as much as we can. So I mean, the critics would say it's just removing the burden from the health service, and I think there's a legitimate basis to that. However, you know, for us, and definitely for me, it's more about the people and element of things. And we all know, if we know what to do when we've got a problem and we feel confident in doing it, and our loved ones and those we live with also feel in that way, you know, we feel empowered to deal with these issues. So I think there's a compelling argument to actually really put a lot of effort at that end of the spectrum to prevent people moving along.
Now, how are you going about measuring, I'll use the word measuring, the success of actually this shift towards self-management and anticipation? How are you going to be able to measure that in terms of the strategy?
Very interesting question. And I'll be quite honest, we're at the stage we published our strategy earlier this year at the end of April, beginning of May, and we are still to complete our detailed evaluation programme. However, we do have high-level indicators already identified. So for self-management, we can easily monitor and measure how many people are accessing this information, but accessing information doesn't always equate with the desired outcome, and we fully appreciate that. So it's going to be a suite of indicators that will go alongside the overall measure to actually indicate how successful this is going to be. And I anticipate that there will be things like, we know what the anticipated impact on, say, GP consultations is going to be, on general practices, etc. We can actually monitor those as well going forward to actually see what proportion of people with these long-term conditions are still accessing the mainstream health services, etc. In our country, and I think it's very common in other countries, community pharmacies have a fabulous role to play in supporting the health needs and information of their local community. And again, that's another area that we're significantly investing in. And also from a digital point of view, making many more options available to pharmacies and how they can engage and interact with people who come along to see them. But big messages about minimising prevention, using local options that are there for you, and then making sure that we put the right bits and equipment and resources and everything else in place to enable that to happen.
So is that part of, I think one of the things you mentioned, you had a vision for health and social care integration from a community setting. So is that an example of what?
Sure. Yeah.
Any other examples that you can give? I mean, the pharmacy, I think, is a really good one.
We have a number of them. We made a promise, if you like, 3 years ago, that we were moving towards total health and social care integration. And we established in Scotland health and social care partnerships, which are our partnerships based on coterminous with the local authority areas. So we have gone from we still have 14 health boards, but we also have 32 health and care partnerships. And their job is to really look after the community angle of things. And they have the ability to spend a budget in the way that their community needs it. And we've seen some really good and creative examples coming out of that, of how they've used their ability to determine what they're doing to meet the needs of their community. And there's been a big digital focus in that as well, they've recognised. So a very good example of that that I can share with you is in the area of cardiac and pulmonary rehabilitation. Mm-hmm. And an initiative was undertaken that actually determined the efficacy of this and was done by a university and well evaluated and trialled, and again was a compelling argument. So one of our major city providers has set up a hub and spoke model with a lot of the community partnerships, and through those then they can run cardiac and pulmonary rehabilitation classes where people in their localities can come to a place that's very near to them. And then they're overseen by, it will be a care assistant. It's not a clinically qualified individual, but it's somebody who's been through the training, so the safety element is covered. And then these classes are run by Telehealth, by somebody in the city, who they can reach over 700 people in one session. Mm. So we knew that the demand outstripped our capacity in the past. So basically, we were not meeting the demand for this type of really valuable intervention. So that's an example of how the partnerships have chosen to actually make available to their local community the ability to actually get this kind of service. So lots of examples, on that kind of level there. But social care integration came formally into statute within Scotland in April 2016. There was a bit of prep work done the year before, obviously, as you can imagine. We're still very young on that journey, and as any system that's run for considerable length of time with different ethos, with different budgets, with different terminology, etc., training, staff, expectations, everything else. So, it's going to take a little while for us to align completely. And without a doubt, some of our 32 partnerships are making faster progress than others, but everybody's moving in the right direction and with quite a lot of central support to help them get there.
Yeah. I know Scotland has been one of the pioneers in telehealth as well, yes, and so have you been able to use some of those networks and whatever, and build on the infrastructure?
Yes. I mean, with regard to, if you like, our digital programme in Scotland, and I'm using for this example the work that we've been doing with the nurses and allied health professions, and in particular, we have a very well-established network. And these are practitioners, healthcare practitioners, who have obviously an interest in any element of digital practice, including telehealth. And as you pointed out, we like here in New Zealand, suffer the challenges of some remote and rural areas. So 1 of 5 of our population does live in remote and rural areas. So telehealth, we've invested considerably in the infrastructure to support some of these communities and environments, and have set up lots of examples where we can have, for example, not only interventions and healthcare given via telehealth, but we also do consultations and peer-to-peer clinician, so you can actually link directly with an expert in that area if you tend to be a more generalist and could do with a little bit of extra information. But a lovely story that I'm very fond of telling is a lady who's a speech and language therapist in the Highland region of Scotland. So again, her clientele were quite remote, and if you can imagine travelling to people's houses, they tend to be people who've had strokes, their mobility is limited, etc., and they live in rural communities. So she was spending half her day driving backwards and forwards to people's homes. And then she got involved in a research telehealth project with one of our universities. Now, to be very clear, this lady perhaps would not be the obvious person you would choose. She was a lady in her late 50s who'd been well established in her practice, etc., but she was willing and really keen to trial it, which she did do. And interesting enough, the results of that study have been published a couple of years ago, and what the outcomes were, that the outcome for the patient was better via telehealth than it was via face-to-face. And so I had the conversation with her about, well, why do you think that is? And she believes it's to do with the fact she prepares better for the telehealth consultation when you have somebody there, but also if you've got somebody in front of you face to face in a sort of a treatment environment, you can be slightly distracted at times. The phone might go off, or somebody come into the room, or something else, as well as the toil on the patient of actually getting to that venue, and may well be quite tired by the actual effort of travelling, let alone the health practitioners. Sort of mood and having driven 94 miles to get to there. So they have converted now the majority of all their interventions to use via telehealth by choice, even if it's for somebody who lives relatively locally, because the clinical outcomes are better and the patient experience is very acceptable. So it's really good to see sort of practice like that, which is what I call truly disrupting the use of disruptive technology in a really positive way and having positive outcomes.
That's great, Lesley. Thank you so much. If I could just put in a quick plug, in New Zealand we've adopted the terminology, and we're gradually getting people to use it. In person,
Yes.
and that face-to-face can either be over video or in person.
That's very interesting.
Whereas in the past, people have said it's in person or face-to-face, and we've gotten the medical council and others to adopt the terminology.
Excellent.
That face-to-face doesn't necessarily mean in person. So we'd say in person or the other. So just a little plug for us.
That's something we'll take away, because I think that's very relevant, and it's also very relevant because at the moment we're finalising some of our standards and our definitions around some of our data items on the informatics side, and I will take that one back.
You can refer to
Excellent.
our Telehealth Resource Center.
I will do that.
Resource
Excellent.
Center. Thank you so much. And because you've done a couple of papers, haven't you? And they will all be on the HiNZ website, all of the papers and slides for people to look at the full presentation. So thank you, Lesley.
Thank you very much for talking. I've really enjoyed it.
Thank you.